Hello everyone and welcome. Thank you for joining us for this brief case-based discussion of point-of-care ultrasound for lower extremity DVT. This is primarily targeted for our third-year family medicine clerkship. However, DVTs are encountered or suspected DVTs are encountered across a lot of specialties, so this could really be applicable to a lot of different specialties and clerkships. So let's jump right into the content. We're going to start off with a couple of cases, and I will just mention that we'll not be covering detailed review of scanning technique and anatomy. To look for further information on that, please check out some of the other videos on my YouTube channel or on the Soul site. This first case involves a 29-year-old female. She has leg pain and swelling, had a recent transcontinental flight, and also takes estrogen-containing oral contraceptive pills. Patient otherwise has normal vital signs, and here's the image that we got for this case, and we will come back to this here very soon. Our next case is a 23-year-old female who has left-sided chest pain. She's 37 weeks pregnant. Here are her vital signs. Heart rate's 104. Pulse ox is 96% on room air. And then our third case is a 62-year-old female who has acute shortness of breath. Vital signs look not too horrible, but a little hypoxia. Heart rate's 112. She has an elevated creatinine at baseline due to her chronic kidney disease, and she also has a documented severe allergy to IV contrast. So with those cases in mind, kind of let those mull over in your brain a little bit. We'll jump into the take-home points and then review some of the decision making when working up or evaluating for DVT, or even patients where PE is kind of a concern on our list. So one of the first things we need to do is assess the clinical likelihood of a DVT, and I'm not going to get into detail on that here, but there are all kinds of different scores, Wells scores. Use those tools to help you assess the clinical likelihood. When doing the ultrasound of the lower extremity, there are 3 deep venous junctions that we need to pay attention to and make sure we include, and then as much as of the deep venous system as we can evaluate efficiently and effectively at the bedside. And the main question is, do these veins, once you identify the proper anatomy, and that's very important, make sure you're looking at the deep veins themselves, do they compress or not? If they compress, there's no clot. If they don't compress, then that means there's likely a clot. And most of the time you'll see some kind of echogenic material that represents some of the thrombotic material. And then just to kind of hit on this topic of DVT study as part of the pulmonary embolism workup, and this, in some certain select patients, this is a way to evaluate for PE or establish the necessity of anticoagulation. So you suspect patient maybe has a PE. If you find a DVT, then that supports treating them. And in some patients, if you find thrombotic disease that supports starting therapy, you really don't need any further workup. If the patient's not super sick, they have some symptoms of a possible PE, and you see a DVT in their leg, you know, okay, well, this patient warrants anticoagulation, so specifically diagnosing the PE may not make that much difference. Or in a patient, maybe you suspect PE and they are quite sick. Maybe they're in shock or they have signs of clear respiratory distress. If we suspect massive or even maybe a submassive pulmonary embolism with the whole clinical picture, and we probably would include ultrasound of their heart, then finding a DVT in an extremity helps to support the decision to administer systemic thrombolytic therapy, especially in a patient who maybe is too critically ill to go for CT scan, or maybe has a true significant severe contraindication to an immediate CT scan. On the converse, in a patient where maybe a PE is suspected, but you evaluate for DVT and you don't find one, so it's negative, that supports maybe withholding therapy until other workup can be obtained if deemed necessary. So maybe they've got some chest pain or some minor shortness of breath, but they don't look that sick. You look and there's no DVT. Maybe you look at their heart and there's no big right heart strain. Maybe that supports pre-treatment for this patient with allergy and then doing maybe a delayed CT pulmonary angiogram. Maybe you need to do a VQ scan. And in certain patients, maybe they have minor symptoms, they're low likelihood, there's no signs of right heart strain, you don't see a DVT. In some select patients, maybe you decide that's enough workup at the moment, in combination with the rest of their history and their physical and other pre-test probability assessment. I hope that makes sense, how sometimes doing a bedside DVT study can be an adjunct in part of your workup for pulmonary embolism, and sometimes obviates the need for other evaluation. So just to introduce a little bit about, again, we're mostly going to focus on some of the findings and decision making. The big disclaimer here is that most every guideline that's out there recommends doing history and physical, risk stratify the patient first. Then in patients who are low to moderate risk but still need testing, doing a D-dimer first, and then only doing imaging if the D-dimer is positive. However, in most clinical practices, if you have access to bedside point-of-care ultrasound, you can complete that before you would ever get a D-dimer result back. So in clinical practice, it may be more efficient to just do the ultrasound instead of waiting for a D-dimer. The next thing I want to point out is that for most published guidelines, doing a proximal leg ultrasound is deemed as equivalent to doing a whole leg ultrasound. Even in some vascular labs, a proximal leg ultrasound is what's primarily done to evaluate for lower extremity DVT. Now, this is a little controversial, but I point this out to let you know that doing a proximal leg ultrasound is adequate in most of your patients, especially in the low to moderate risk patients. And we'll talk about that in a little more detail. And from the emergency medicine literature, where most of the literature for point-of-care ultrasound has been done, it's been shown that a quality DVT point-of-care ultrasound is equivalent to a proximal leg ultrasound in a vascular lab. And we're going to talk about what a quality DVT point-of-care ultrasound consists of. Here's just a little bit of the algorithm on how to think about it and how to do your decision making. If the patient has a low likelihood of DVT and you have a negative point-of-care ultrasound, you're done. They don't need any further workup. They don't need a follow-up ultrasound. They don't need a repeat ultrasound unless they have persistent or concerning recurrent symptoms. So that's what I generally tell patients. If they have leg pain, but they're pretty low likelihood, we do the ultrasound at the bedside. If that study is negative, I tell the patient, if the symptoms don't get better or they persist or they get worse, you may need a repeat ultrasound. But if the symptoms resolve or they don't really change, you don't necessarily need to have any repeat imaging for DVT. If they're moderate or even high risk and you have a negative point-of-care ultrasound, then they need a repeat within a week. So not tomorrow, not 24 hours. This can be done sometime in the next week. So for my ED counterparts, you're doing this, say you do it at night and you have a negative study, that patient doesn't need to come back to the emergency department the next day. They can have a scheduled DVT ultrasound sometime in the next week. The one caveat is in patients who are deemed to be high likelihood, have kind of objective findings of maybe a swollen leg, but a DVT is not seen in their lower extremity, and maybe you suspect a proximal, so like an iliac or some kind of pelvic DVT. Those patients may warrant fairly immediate, emergent, or urgent imaging of the proximal pelvic or iliac veins with either CT venogram or MR venogram. This is a pretty rare phenomenon, but it does happen. It has been reported. I've personally seen it, so those patients are out there. If you look at someone's leg and you think, I'm certain they have a DVT, but you don't see it on your bedside ultrasound, and you have concern for a proximal DVT, then think about that other imaging to evaluate the iliac veins in the pelvis. Okay, some quick reminders. Identify the deep veins that are in contact with the deep arteries. The number one mistake people make is they just don't evaluate the anatomy appropriately and they'll get focused on superficial vessels. That's the number one mistake I see people make. Always make sure you identify the deep arteries first and look for the deep veins in contact with them. Once you find them, just look, does it compress? Yes or no? And then one other thing that I'll typically do is if patients have a local area down in their calf of redness or swelling, go ahead and evaluate that area and look for any of the deep veins that are in association with that swollen or objectively red area and see if you see any non-compressible veins in that area, and then decide if those are deep veins or not. And kind of mentioned already, any other localized symptoms. So even though you've done a proximal DVT study, if they've got clear objective red swelling areas in their calf, go ahead and evaluate those areas to look and see if maybe there's an abscess, maybe there's a superficial phlebitis, or maybe there is a deep vein associated with a deep artery that may help you lead you to the diagnosis of a calf DVT. So some of the pitfalls, some of the things you need to watch out for. The number one thing, like I mentioned already, is just getting focused on superficial veins and not finding the deep vessels in association. So here we see these little veins. You see they're just we just see subcutaneous tissue all around them. We don't really see any muscle layers. So these are not deep veins. If you see this and you think, oh, that's negative, you have made a big mistake and you might have missed something important. So those are superficial veins. So always make sure you have adequate depth and find the big deep arteries in association with the deep veins. Same thing is happening here. These are actually superficial branches in the popliteal fossa, and the deep veins are way down deeper. In this example here, someone's focused on these superficial veins when in fact this is the deep vein and it's actually full of clot. It was nearly missed because someone got focused on these little tiny superficial veins. So always make sure you have adequate depth and make sure you clearly identify the deep arteries and then the deep veins by association. So these are the same studies, only with the depth corrected. So those little superficial veins are barely visible when we get adequate depth. And the artery, I believe the artery is here. It's not super clearly seen, but this is a giant dilated vein full of acute thrombus that would have been missed if you just kind of focused at this superficial depth and those superficial veins. And this is an example, again, case from the last slide, only with the depth adequately fixed. And what we identify is the artery is deeper down here, and we're kind of at the branch points of the trifurcation of the popliteal vein, and we see multiple veins that just will not collapse because they contain clot. So again, cannot emphasize this enough. Make sure you get adequate depth, identify the deep arteries, and then the deep veins in association. Other minor pitfalls, sometimes you may see lymph nodes that are swollen, and these can be mistaken for DVTs because they kind of look like, they're round things with echogenic material. If you're very meticulous about identifying the anatomy, the deep arteries, and then the veins in association, you probably won't make this mistake. And just follow them. As you track them up and down, the lymph nodes will kind of just come and go and disappear, whereas the veins and arteries, they're pretty much continuous throughout the lower extremity. You should be able to follow them through the length of the extremity. But here's a swollen lymph node in this example, and you can see it's superficial to the vessels. Here's a lymph node, kind of comes in and out of view right here. You can see that. But again, it kind of comes and goes as you fan through it. And here, we're kind of just next to vessels, and this is a little tiny lymph node. It's not really swollen. You probably wouldn't mistake this for a DVT, but those can sometimes be mistaken. Fan through them, look for the vessels, look for the arteries. If you're meticulous about identifying your anatomy, you probably won't make this mistake. So those are the main pitfalls. Superficial veins is the number one thing, so always make sure you have adequate depth. Find the deep arteries first. Lymph nodes, just fan through them, and again, be meticulous about identifying the anatomy. One other thing that can sometimes be difficult is if your transducer is not kind of vertically aligned against the vein as you compress, you'll be compressing at a different angle than the vein you're actually visualizing. So once you're on the veins, try to align yourself as vertically as possible as you compress it to identify that it's compressing appropriately. And a few examples of positive. For the most part, again, this is just, does it compress, yes or no? So in this example here, this is the left femoral artery. Here you see it pulsing, and we see the vein medially to that, and it doesn't compress, and we can even see there's probably some echogenic material in there. So yes, this is a DVT. This is another example. This looks like a right femoral. So again, we see the pulsatile artery. Always find the arteries first. We find the vein in association. And again, it's got echogenic material in it and it doesn't compress. So this is again another example of a femoral DVT. Now we're in the popliteal fossa. First, we make sure we identify the deep artery. We see it pulsing here, and we see we're kind of at the trifurcation. So we see multiple branches of the popliteal vein, but again, they don't compress. We can almost get a little hint of a little echogenic material here in this popliteal vein. So this is a popliteal DVT. And it looks like maybe at least one more. Again, here's the artery. It's got a thick wall. It's pulsatile. And then we see the vein medially. So this is the right side, and it won't compress. You can kind of see the compression action happening, and we can even see some echogenic material in there. So this is, again, an example of a femoral DVT. And here we're in the popliteal fossa, so the artery is deep. We see the popliteal vein sitting superficial to the popliteal artery, and again, it's not compressing, and we can see the echogenic material within. So this is a popliteal DVT. So just reviewing our cases real quickly. So this is our first case, the 29-year-old woman who flew cross country while taking her estrogen-containing oral contraceptive pills. And we can see this is the pulsatile popliteal artery. Superficial to that is the non-compressing popliteal vein that contains some echogenic material in it. So this is a DVT. This is something you could diagnose in your clinic or in an urgent care, in the emergency department, and immediately make the decision to start this patient on direct oral anticoagulant and discharge from your clinic or from the urgent care or from the emergency department. And these can be a very quick visit. If you rule it in, it's a quick visit and a quick decision. And if you rule it out, very quick visit and a quick decision. So this can make your practice a lot more efficient. So this is our second case, this 23-year-old female with chest pain. She's pregnant. Vital signs, they look pretty good. Remember, your heart rate can be a little higher in pregnancy. So the patient's not super sick. So not someone we think has a massive or a submassive PE. And if we're concerned about that, we should probably look at their heart as well to look for signs of right heart strain. Look for that in a different video. In this case, we find the femoral artery and the femoral vein here is not compressible. We see echogenic clot within here. So now we have a patient that has a known DVT, a known rationale for anticoagulant therapy. And who's not sick enough that we're worried about a massive PE. We're not worried about pushing thrombolytics or performing embolectomy. So in this patient, we can just start therapy. We've got the rationale for treatment. We have a diagnosis. We don't specifically need to visualize the PE to know, hey, this patient needs anticoagulation. And as mentioned, probably incorporate your echo skills into this patient's care. And here's our third case. We've got a 62-year-old female with acute shortness of breath, a little tachycardic, a little hypoxic, but has some reasons maybe you want to be a little cautious about CT scanning and contrast. Well, if we take a look, now we are going to show the echo. So this patient has, so this is the left ventricle. You see that's kind of compressed by this dilated and significantly enlarged right ventricle with septal bowing and McConnell's sign. And in the left femoral, we see this massive big DVT in the femoral vein, this non-compressing vein. Believe the arteries here. It's kind of off the screen because it's so big. So now we have a patient with signs and symptoms that are consistent with a massive pulmonary embolism. We have, heart rate greater than systolic blood pressure. We have right heart strain and a DVT. This is enough right here to make the decision to administer systemic thrombolytic therapy or move this patient for embolectomy if they have contraindications to thrombolytic therapy. So I hope those make sense in kind of the DVT workup, but also in the patients where you're considering pulmonary embolism. So again, just reminders, the kind of DVT algorithm of how to make these decisions and how to think about these patients, assess their likelihood. If it's a low likelihood patient with a negative point-of-care ultrasound, you're done. No further workup is necessary unless the symptoms persist or don't get better. They're moderate or high, but you have a negative point-of-care ultrasound, they can repeat within 1 week. The caveat being in patients who are highly suspicious of a proximal kind of pelvic or iliac DVT. Not very common, but something you got to keep in mind. So last little bits of summary. This is an easy exam. It's quick. It's accurate. It can be done in a few minutes at the bedside and make you much more efficient. Make sure you're always finding the deep arteries. Try to compress those veins vertically. And your main question is the vein collapsing, yes or no? If it does not collapse, then there's probably a thrombus in there. Thank you for tuning in. I hope that was helpful, and we'll see you in the next one.